Hey guys. So, a little bit different today. We usually do PowerPoints. PowerPoints are really important to get across information. The other important thing is to make them short and sweet so that you get the information, but you're not spending an hour watching a YouTube video. The other thing is, if I can keep it under 10 minutes, then I could just email you the video. I don't believe that that's going to be the case at this point. That being said, my husband actually told me that I'm a slow talker, which I'm not sure that I would ever be considered slow talker. So if you want to watch me at 1.5, just go down to the bottom and speed up the speed that I discuss this at, but make sure you get the information. So we're going to talk about discharges, and this came up because one of the nurse practitioners said that the physician in her building said, you're outright not to do any discharge planning with my patient. You're not to do the discharge summary. You're not to talk to the patient about any of that. We don't need that filled out. That being said, I did look into CMS and Medicare to find out if we could do our own discharge summary if the physician did that. That being said, a primary should not be doing a discharge summary. So maybe pain management or psychiatry would be doing a discharge or closing out the chart. But if the physician has already closed out the chart, we're not going to close out the chart. So this is a three-way split on the video. First of all, if you're not doing discharges, you need to be doing your discharges. So that's super important, and we'll get to why that's one of the most important notes in the chart. So that's the first thing. The second thing is, if you've got a physician in the building that is not allowing you to do discharge summaries, I've got a plan for you. Third thing is, if you have no physician doing discharge planning, discharge summary, discharge notes, and you have the ability to do that, we have 2 notes now that you're able to do, and so you'll be able to capture both of those for your discharges, and now it's a 2-for-1 deal. So lots of good information. So again, I'll try to go as fast as I can. We're talking about safe discharge documentation and the transition of care framework. This will be sent out to everyone. So writing a safe, high quality discharge summary. So the reason we do that is because we're handing off the patient to somebody else. We've talked about this before. We've talked about if the patient is going to the hospital and they request our records, patient in the primary care when they go back out into the community, patient at an assisted living or with home health. So when we send the patient off and there's no gaps in care, the patient gets a better consistency and continuity of care and a decreased risk of adverse effects such as return to hospital or deterioration, delay in medication, etc. So why does it matter? We've already just talked about that. So the 3 components starting out with a high quality discharge summary. So when we're talking about, and I should say high quality discharge summary for your HPI, we're looking for 3 things. We're looking for the first paragraph to be the hospitalization summary. So a concise clinical context for why they were hospitalized, what happened during hospitalization, and then the condition that they were in when they transferred to the facility. That's going to be your hospitalization recap. You can take that recap from your very first note that you did, and that's what the first paragraph could be, and you can put it in your hospitalization recap. They've been there 1 month, 2 months, 3 months. That's part of your discharge summary. So that's very important. The second paragraph is going to be something that you're going to have to negotiate, figure out for yourself. But it's what happened while they were there at the skilled nursing facility. So what are we talking about? What problems were being addressed, whether that was a stroke, whether that was a fracture, whether that was status post-pneumonia, osteo, whatever it is. The rehab, they participated in skilled physical and occupational therapy and has now improved. They're now ambulatory. They're now able to do ADLs, etc. Medical stabilization, wound care summary, if applicable, please put that on there. Any IDT care highlights, and then the condition at discharge. And then your disposition. So where the document where the patient is going, Super important. They're going home to an ALF, to a hospice house, and whom they're going home with. So that's very important. Home alone, home with family, etc. So, and the assessment and plan, that is where we're telling people what the patient's most important assessments are. So diagnosis, assessment, plan. Remember to follow that protocol. So this is going to be like any other regular visit for the first half of that. And you're going to list 3 or 4 most important, most relevant problems, okay? So that's what our focus is going to be on. Not every single one like we're doing for an admit. We're going to reflect the status. We're going to avoid progress note style monitoring language. So we're not going to say or tell somebody that you're going to monitor the patient or that you're going to draw labs or that you should follow up. Again, you're handing the patient off. Let them make their medical decisions from there. Frame the plan as a transition of care rather than ongoing management. Continue to monitor. Nope, remove that out of there. So your assessment and plan should be very blunt and very minimalistic. So you've got your diagnosis of hypertension. Your assessment is patient is hypotensive, hypertensive, normotensive, with a blood pressure of whatever. Blood pressure logs reviewed and were stable across the past 2 weeks or prior month, etc. Continue Norvasc 5, etc. So we're going to do our drug and our dose. If there's any antibiotics, make sure you're giving a stop date. If there is Lovenox, you better make sure that they still need that to go home and that you've got a stop date. If they had a blood clot and we're only on Eliquis for 5 minutes, I don't know why I said 5 minutes. The whole house just lost its power. Again, sorry. For 6 months. So they're only on Eliquis for 6 months. Make sure you've got that stop date. So whoever is taking over care of that will work. I'm hoping that this video didn't get affected by that. And then medication reconciliation, all discharge meds, drug, dose, route, frequency, and indication. I'll show you what that looks like. It's very important that as we're doing this, that we're not just copying the medication that comes from point-click care, that you're actually sorting those drugs out and resolving them. So I'll show you what that looks like as well. The PRN medications don't come over with every 4 hours, every 6 hours, every 8 hours as needed. It also doesn't come over as needed for pain or as needed for severe pain or as needed for nausea or vomiting. So those parameters are very important to do. Again, wound care, give them the exact dressing change, copy and paste that. We want a follow-up plan that is clear that the primary care out in the community or out at the ALF can do. If you've got the specialists that they've been following, put that on your note. Follow up with orthopedic, doctor, orthopedic man at this phone number, at this address, as needed for any orthopedic issues. So make sure that if they were here for ortho, they're following. If they've got pulmonary, if they've got cardiology, if they've seen those doctors while they've been in the facility and you just want them to be seen, follow up as needed, write that on there. So remember on your discharge, that is a handoff. It's not a progress note. We're going to prioritize and minimize what we're documenting with maximum output. We don't want any copy forward documentation except for a concise hospitalization recap. Please don't copy and paste. Please don't pull things forward and leave them. Please don't use unadjusted snippets. Okay, a well-crafted discharge summary supports continuity, our ownership of the patient, and then our transition or our handoff for every patient. So let's get into what a discharge summary looks like. And I've done a lot of work for you guys, so I'm hoping this helps. 2 things. 1, there's a discharge, and then 2, we're going to do a pre-discharge, and we'll go through each of those. Now, for a discharge summary, This whole process of from here on down is going to be how to use these snippets that I have made for you guys. So under chief complaint, it's discharge. And then that is what the snippet is called. And it says discharge, comma, and then you were to fill in an actual diagnosis. For those that think that your chief complaint can be admission, that's it, or follow-up, and that's it, that is not correct. Your first assessment plan is your chief complaint. So that being said, it has to be tied to an ICD-10 code. So you need an actual diagnosis here. Your HPI, you're going to use the snippet discharge, use for 99316. That is the snippet that it's called. And what that snippet says is the IDT reports that the patient has met rehab goals, needs a lower level of care. Social work reports that the patient will be discharged to. Now remember, my snippets are only half done. I only give you half of the snippet. You have to do the rest. You can't just click the snippet and then, because this is signed with your name, it drops into point click care. It's very important that this note is written specifically. So discharge to home, ALF, delete what is not applicable at the time. And so whatever is, leave it. And they're going, where are they going? Whom are they going home to? So they're going home with home health or caregiver support. I would write daughter, spouse, family, something that identifies who they're going home with. Discharge meds were reviewed with the patient. If the patient's not alert and oriented, did we discuss it with the spouse? If they're going home with the ALF, did we forward that on to the nurse? Instructions were provided to continue medications on the discharge medication reconciliation and avoid understanding of and avoid resuming medications taken prior to hospitalization unless specifically directed. And so this is a whole new start. You came from the hospital. We've got you on all different medications. So whatever you were on before that, you're not on. And then this is my standard 7 to 14 days. We're here in Florida, but for everyone across the country. So wherever your facility is, we could be Texas, we could be Pennsylvania. We got to follow up within 7 to 14 days. If you tell them within a month, on day number 28, they're going to try to make an appointment, and then they're going to realize they're out of medications because we're only giving a 30-day supply of medications, 7 days if we're talking about a C2. So it's very important that we give them a deadline, 7 to 14 days. At day 14, they're going to go, oh man, I forgot to make an appointment. They make an appointment. It takes them another week to get in. They still have their 30 days worth of meds. So it's very important that we either help them make their follow-up appointment or that we make sure they're aware they need to do that. So under medical decision making, there's actually a snippet called discharge. It's the same one that's been there. And it just says the time spent was approximately 35 minutes. Please change that. Anything over 30 minutes. And you will be taking more than 30 minutes. None of these notes should be less than 30 minutes when you're talking about assessing the patient, reviewing the chart, reviewing the medications, and then documenting. These charts are going to be very robust. So if you're using 37 minutes, 40 minutes, 45 minutes, whatever your time is, and then time was spent with discharge instructions, education, safety, nothing new. And then under the discharge summary, there is a snippet called medications discharge 99316. Again, I've labeled these 99316 because that's the code we use for discharge. And so your snippet, I want you to be aware that we're doing two different things. One is a discharge, one is a prep for a discharge. And so this is associated with the discharge. So, and it's just saying final medication reconciliation was completed and reviewed to support safe transition of care. See here that you've got and or fix that. What is it? Delete the wrong one. Medication indications, dosing and administration instructions were provided, and understanding was confirmed, meaning that your medications were reconciled and completed. So if you are allowed to do a discharge, we're going to want to do a discharge. So if you come in here we talked about our chief complaint. There are several now in here. So here is a pre-discharge reassessment. It tells you the billing is a 99309 or a 99310. That is not the one that you want. You want the discharge one. And it says discharge diagnosis. You're going to delete that and put hypertension or whatever their diagnosis is. But that is your chief complaint, and I've given it to you so that you have that. Your hospitalization recap, copy that from where it's supposed to be. As far as your HPI, you're going to be writing your initial statement about the age. Then you're going to have your second paragraph, and your second paragraph is going to, I love our little red squiggly lines. Our second paragraph is what you have to write independently. I don't have the ability to do that. But if you scroll down, remember these are based on characters first, numbers second, and then alphabetical. So discharge. So this is IDT reports the patient has met their goals, no longer requires skilled nursing care, appropriate for a lower level of care. Social worker reports that they're going to go wherever with home health, and then instructions to follow up. You saw that on the note that I just gave you for education. I've given you the snippet that you don't have to do much work with, but they do have to be adjusted. That second paragraph is going to be how the patient progressed. So if I go to this section right here, and it's going to be section 2, it's going to be your second paragraph. So what went on during the stay, the problems, the rehab, and I'm okay if you do rehab, participation, and response, and you wrote patient, and you just copied what the patient was on skilled physical therapy for, copied what the patient was on skilled occupational therapy for, etc., etc. But that second paragraph is yours to write. Second meaning this is your first paragraph, and you're going to copy that from your original hospitalization recap. This is going to be your second paragraph. Again, using snippets, but making sure that you're documenting correctly. And then this is your third snippet or your third paragraph that you're talking about and how they're going home. So when you come into this education, you've got your hospitalization, what happened during the facility, and then where they ended up going, why they're going home, blah, 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 because they're stable, okay? So scrolling down a little bit further, your medications should already be pulled in. As far as going down to your time and medical decision making. Now this is a discharge, remember. So this is a 99316. So there is actually a discharge one here, approximately 35 minutes. You change the time to whatever you want it to be. It's got to be over 31 minutes. And then it talks about the time that was spent with discharge, exactly like I just went over a couple of seconds ago. So there's your time and medical decision making. Now you're going to have to open up, this is an initial note. You're going to have to open up your discharge summary. So let me get to that. Okay, here I am back again. Discharge summary. This is just a blank patient, an empty fake patient. Discharge summary. You're going to do your admit date, your discharge date. You're going to do your primary MD. You're going to do the disposition. So it tells you a whole bunch of places. Where are they going? I've given you a lot of options here. Their condition. How is their condition? I've given you snippets here. How is their activity? So partial weight bearing, non-weight bearing. Do they need assistance? Ambulation. So lots of choices here. I've given a diabetic diet. A lot of people are just writing regular diet, and when you look, you're seeing that they're not. Or their assumption is they've got a diagnosis of diabetes, so they're on a diabetic diet. Make sure you look to see what diet they're on and put that in there. Now your medications. Now if you want to copy from above, you can indeed copy from above. So when you do that, you're going to need to space them out. So when we did new hire orientation, I'm like, don't take the time to space these out. However, there's going to be a lot of things that you need to address on these. And I'm only going to do a couple because of a time constraint. So you're going to look through these. The atorvastatin 40 milligrams at bedtime, that's fine. Lactulose 10 milligrams to 15 milliliters every 12 hours. Well, how much are they supposed to get? So I would put specifically, give 15 milliliters. So the daptomycin, if they're not going to be on daptomycin, let's say you've discontinued that in 2 days, and this is your discharge summary, and they'll be going home in 2 days. So they're going to finish their daptomycin. You just delete this out. Just fair and square. You know they're not going home on daptomycin. Delete that out. You've got your pregabalin, 150 milligrams every 12 hours. You've got your Lexapro, 10 milligrams every day. Let's say that they're not going home on this IV antibiotic either. You're going to delete that out. Now, you've got your Miralax that they're taking 1 time a day. I don't know how much they're taking. I have no idea. Well, I do, 30 grams. But we would like to say 1 capful, 1 packet. However, we are going to explain that to them. Sodium chloride, we're going to have finished our antibiotics, so you've got to take them out. Your TBs, you're going to have to take them out. A lot of people want to just copy that entire paragraph and put it down here. And so it's very important when we're looking at your discharge meds that they're accurate. Okay, so let's say we go to a skilled nursing facility. We all have template medications that you can get from the provider. And so those are going to be your Dulcolax, your milk of magnesia, and your Fleet's enema. Nobody goes home with a PRN Fleet's enema. Nobody goes home with a milk of magnesia or a Dulcolax. So when I say we're looking through these medications, I want them to be looked at and I want them to be accurate. So here's one right here that I want to make mention of. So here is an acetaminophen, 325 milligrams as needed. So you're going to have to write, take 2 tablets by mouth every 4 hours as needed for pain or fever or whatever you're going to write. But realize this is the only thing that comes over. So if you're copying your medications from above, you're going to have to edit them. And I'm 100% okay with you copying. What is not acceptable is leaving a whole bunch of things, having them all in a paragraph where it's not easy for them to understand what they're supposed to be taking. So make sure you do spell that out for them. That being said, at the beginning or the end, it doesn't really matter. Interesting that my snippet isn't there. There should have been a snippet, and I will check to see where my snippet is because it has disappeared. But the last part of that was the snippet that says final medication reconciliation, and I will get that on there. Was completed and reviewed with patient and or caregiver to support transition of care. So that being said, there is your example of a discharge note, okay? So now let's take it a step further. We're going to take it a step further, and I'm just going to change this really quick. Okay, so now this is a pre-discharge reassessment. You're going to use this if your patient is discharging and you know 3 to 5 days in advance. So you can use this, and a couple of days later, you can actually do the discharge assessment. So if you're only doing your discharges and doing a great job and you have the ability to do that, you can tack this pre-discharge assessment on top of that several days prior. So on Monday, you find out that they're going to go home on Friday. You can do this pre-discharge reassessment. It's a reassessment of the entire patient. You can do that. And then on Thursday or Friday, then you can do your discharge assessment. On the nurse practitioners that are not able to do that discharge assessment and capture that 99316, we give you the ability to do a pre-discharge reassessment, which will be billed at a 309 most likely, but potentially a 99310. So if you're sending a patient home, they're usually stable. If you're sending the patient to the hospice house, then they may not be stable. And so that might change depending on what you're doing. Your chief complaint, the template is going to be pre-discharge reassessment. Again, we're going to do this day 3 through 5 before the discharge. And then if you can do a discharge, do that discharge several days later. If you cannot, at least you've got a discharge plan in place. So your chief complaint, the template is pre-discharge assessment. Your HPI is pre-discharge reassessment, paragraph 2. So you're going to use this for 99310, 310, and 309. So that is your snippet template. And so it's for paragraph 2. The patient was evaluated in preparation for anticipated discharge. Now remember, my snippets are not perfect. So you do have to go in and edit them, adjust them, delete stuff. So read them line by line, like every single section. Medication regimen was reviewed for accuracy, functional progress, and overall readiness were evaluated. Meaning, did you talk to therapy and see if by Friday their plan is that they're going to be improved and ready to go home? And then the patient remains appropriate or not yet appropriate, meaning we're getting ready to discharge them by Friday and they're not quite there yet. So CMS might say, if you're doing a discharge note 5 days in advance, and the terminology CMS uses is several, so they don't give you a day of how soon you can do a discharge assessment, but the word is several days in advance. But if you're doing it 5 days in advance, you should be doing a pre-discharge reassessment. So the patient remains appropriate or not yet appropriate for anticipated discharge pending continued stability. Your medical decision making is going to be pre-discharge moderate MDM. It's a 99309, and it just says that this visit meets criteria for a moderate degree of medical decision making due to the presence of multiple chronic medical conditions requiring ongoing management, that you've looked at clinical records, therapy progress, IDT recommendations. This is you sitting in morning meeting and them talking about the patient getting ready to discharge home. That's IDT. That's your interdisciplinary team. So going to morning meeting and then getting that clinical data is really important. Now, if you don't go to morning meeting because you go to multiple facilities or they just don't have a formal one, you going to the unit manager, talking to the nurses, making sure therapy's good, social services, hitting social services on the way out. MDS, that's interdisciplinary documentation as well. And so that's your medical decision making. So it is pre-discharge moderate medical decision making. And then there's an MDM that's pre-discharge 45 minutes, a 99310. And that's saying that you've spent 45 minutes. So time was spent performing a comprehensive pre-discharge clinical reassessment to evaluate current medical stability and readiness for anticipated transition to a lower level of care. It talks about the activities you did and additional time that was dedicated to a detailed medication reconciliation, which you just saw me do on the last one, the medication reconciliation on getting rid of the daptomycin, getting rid of all of the other stuff, and making sure that the patient's med list is actually accurate. And they're not going to the hospital and requesting the last medication record and the facility sending them a 35-page medication administration record. This is what that's preventing, is that you've done a thorough reconciliation, all the meds are appropriate at this time, and that the patient is stable to go home. And then under discharge summary, under your medications, medication regimen reviewed in detail for continued appropriateness and safety. Polypharmacy risks were assessed in preparation for anticipated discharge. So what does that look like? Well, if they're on 4 antipsychotics, 3 anticholinergics, 4 blood pressure medications, maybe they're not the fittest person to go home. So we have to look at that. Again, here's my fake patient. It's a demo patient. I'm going to come to chief complaint, and I'm going to go to the pre-discharge reassessment. I still want this hospitalization recap, so make sure you put that on there. This snippet is for when they were hospitalized and came back to the facility, or came to the facility initially. A lot of people are doing an amazing job on their hospitalization recap, and yet forgetting now why they didn't go home, why they came to the skilled nursing facility. So that's what that snippet is. Under your HPI, again, it's alphabetized. And so here's your pre-discharge reassessment. So that's your second paragraph. Patient was evaluated today. They're improving, stable, improved, plateaued. Medication records were reviewed. The patient remains not yet appropriate for anticipated discharging pending continued clinical stability. This is saying, I would, in my opinion, write remains appropriate for anticipated discharge, but not yet appropriate for anticipated discharge pending continued clinical stability. If able or if appropriate would be written. Now, this is the second paragraphs of this HPI. So you need to, again, start with your age, and then you need to do this portion. Let me get down to the medication list. I won't even go through the medications because we already did the medications on the last one, and they're the same exact. So here is your first paragraph. This is what happened, why they were there, the major problems addressed, rehab participation, response, and all of that information. That's your second paragraph. So after we've discussed what the patient was there for, that's the most important. So here's your first paragraph. So this is your first paragraph on the HPI. This is your second paragraph down here. We're going to continue to scroll down, assuming all of this is filled out. Again, this is a fake patient. Under time and medical decision making, again, alphabetical. We're going to look for the pre-discharge moderate. So under here, it's time or medical decision making. You don't get to use both. So always start everything with time, and then you can do pre-discharge moderate, 99309. That means you've just discussed 2 or more stable conditions and have had a collaborative discussion. So you can use the 309, or if you did an extensive amount of medication reconciliation and you reviewed the chart and things were getting discontinued, such as whatever, or you're writing orders for the discharge, whatever that entails, you do have the time and medical decision making on there. So the difference, you've got a discharge and then you've got a pre-discharge. So again, your discharge matters, very important. I've given you the majority of the snippets. Again, make sure you please edit my snippets. So I've got a pre-discharge and then a discharge. Pre-discharge would be 3 to 5 days in advance. A discharge would be a day or two. If you cannot get in to do that discharge because the physician is saying, I'm the only one doing the discharge, do the pre-discharge reassessment if you can. But we would like to see one of these on every single patient. It's not a money thing. It's not a compliance thing. What it is it's a very important handoff. You're now sending the patient into the care of another provider. And as frustrated as you are when you get a new admit and you don't get all of the data, we want to make sure that our notes reflect that. The last thing I want to remind you of is if you're billing on time, the date that you're doing it needs to be completed. So you start the review, you see the patient, you do your documentation, you lock it that day. That's how you bill on time. So if you're doing that 3 to 5 days in advance, you go ahead and lock that. If you're planning on doing your discharge, you can leave that discharge open, not the pre-discharge. You leave the discharge open. So you do the pre-discharge on Monday. On Wednesday, you do the discharge, anticipating they're going home on Friday. You do that discharge. You leave it open. The patient walks out the door on Friday. You go back to Wednesday's note when you did the face-to-face and you lock it as of Wednesday. This was a lot of information, but I've done a lot of work to get you to an easier place where you're just doing minimal adjustments, except for your big chunk of HPI, what was going on during that visit. So I hope that helps. Please reach out if you have any questions. Tatiana and I are willing to go through this, discuss this with you. Again, if you didn't watch this at 1.5 speed, I hope it didn't carry on for too long, but I think it was important enough that this transition from the patient skilled nursing into a different area helps. And so if you, again, any questions, let me know. I am going to send this to all of you, and I hope you have an amazing day. Take care. Just kidding. Now I'm going to say take care.